Good morning, everyone. My name is Safa Nizam and I'm presenting as Finance Manager. I'm here to discuss the topic workforce sustainability and service capacity and how it affects my role as a finance manager. My role is to make sure that our healthcare systems are financially stable while still providing good quality care to the patients as a finance manager. My role is to ensure that our healthcare systems remains financially sustainable while continuing to deliver safe, effective and equitable care to our population. Currently, Hertfordshire's healthcare system is facing significant financial pressure. This is largely driven by rising inflation, workforce instability, austerity, and insufficiencies in service delivery. These challenges are not isolated, they are interconnected and are collectively impacting both the cost and quality of care. Right now, the system is under a lot of pressure. The key challenges we are facing is first, the costs are highly rising because of the inflation. Things like staff salaries, energies, and medical supplies are becoming more expensive, but funding has not increased at the same rate. The second challenge we face is we have high staff turnover, especially in care homes. Because of this, we rely more on agency staff, which is more expensive and not sustainable in the long run. Third challenge is we are not investing enough in preventive services such as diabetes care and smoking support. This is a problem because when prevention is weak, more people end up in hospitals later, which costs much more. The treatment costs more than the prevention. Also, there is a lack of coordination between NHS, the council, and voluntary services. This leads to duplication and waste of resources, meaning we are not using our budget effectively. These challenges we face, we have the key financial and management frameworks to reduce these challenges. Firstly, the theories we used are value-based healthcare, which focus on maximizing outcomes relative to cost. This means spending on services that gives us the best result, especially prevention, which saves money in the long term. Second, framework or theory which we use is resource dependency theory, which highlights that healthcare systems are influenced by external factors such as funding and workforce availability. This reinforces that need for integrated financial planning across the sectors. Thirdly, we use healthcare principles which should reduce waste by improving efficiency and make us every service we fund is actually useful and deal with these issues. I have a few recommendations for these challenges. First, we should invest more in prevention, such as diabetes and smoking services, to reduce future hospital costs. Second recommendation is we should use reduce spending and efficiencies agency staff by improving staff retention and supporting our workforce better. Third recommendation is we should combine budget across NHS, council and voluntary services so we can reduce duplication and use money more effectively. The fourth recommendation, we should use digital healthcare like online consultations and remote monitoring to save time and cost. In terms of prioritization, I recommend protecting high impact services such as preventive care and care home staffing, transforming services through integration and digital innovation, and reducing low value or duplicated services. In conclusion, as a financial manager, financial stability cannot be achieved through service cuts alone. It requires strategic investment in prevention, integration, and workforce stability. Three of them. By adapting this approach, Hertfordshire can reduce long-term cost and improve population health outcomes and build a more sustainable healthcare. Let's discuss about the financial role. Do you guys have any questions regarding my role?
Yes, Safa, I would like to ask you a question. As a financial manager, if we reduce funding in some areas, how do we ensure the patient care is not affected?
Um, uh, Sony, for your question, I would like to say that the prevention requires upfront investment. I agree with that. It actually reduces the cost in long term. For example, if we manage diabetes early, if we prevent it early, it's much cheaper than treating it with the surgeries and other treatments afterwards. So by investing in prevention, we can reduce future pressure on the systems and improve the patient care and outcome as well.
Okay,
Yes.
thank you so much, Safa.
I also
Any
have a
other
question.
questions, guys?
Yeah, I have
Yeah,
a
sure,
question.
Mavi.
So, can you explain why we should invest more in prevention when we're already facing budget constraints and all of that? Can you just explain more on it?
That's a very important concern. The goal is not to reduce the care, but to spend it smartly. We have to budget our finances more smartly. We should focus on protecting high impact services and reduce only those that are of low value or duplicated. This way, the patient safety and quality of the patient care is more prioritized. Thank
All
you.
right. All right. Thank you
Any
for
other
that.
questions, guys?
No, we are good. Thank you so
No.
much for your
Thank you.
Thank you.
presentation.
Thank you.
Okay. I'll be presenting next. I am Juliet Chamaka Lawrence, and I am presenting as the Director of Operations. For workforce sustainability and service capacity describe our ability to maintain enough skilled staff to deliver safe and effective care over time. From an operational perspective, this challenge is particularly complex in Hertfordshire. We have high staff turnover in council care homes, which has led to unstable rotas, agency reliance, and reduced continuity of care. There is also a shortage of trained staff in the voluntary sector, which limits prevention services and increase pressure on acute care. Rising costs due to inflation reduce investment in staff development, while low service uptake and declining public trust increase inefficiency and risk in service closure. Together, these factors weaken operational resilience. For the theories and management I would apply, to analyze these challenges, I would apply transformational leadership theory and open system theory. Transformational leadership theory focuses on motivation, engagement, and shared purpose. High turnover suggests staff feel disengaged and unsupported. Strong transformational leadership help rebuild morale, align staff with service goals, and supports retention during pressure. I also have open system theory, which views healthcare as an interconnected system influenced by external factors such as government funding, inflation, and labor shortages. Challenges in one area like voluntary sector create pressure across the whole system. This shows the importance of integrated operational planning rather than isolated solutions. As Director of Operations, my role is to stabilize services while supporting long-term workforce sustainability. This includes improving workforce planning to reduce agency reliance and improve rota stability. Services should prioritize high-impact areas such as care homes and long-term condition management using blended digital and face-to-face delivery. Close alignment with HR ensures training, supervision, and staff well-being are being protected. For strategic recommendation and justification, my recommendation is to keep services open but redesign them through a workforce-centered operational model. Closing services may save money short term, but it increases long-term demand, worsens health inequalities, and reduces public trust. Maintaining and redesigning services supports prevention, workforce sustainability, and long-term service resilience. Thank you. Do you have any questions?
Yes, Juliet, I do have a question for you. So, as a
Okay.
director of operations, how would you like to prioritize services when your workforce capacity is very limited?
Okay, that's a good question. I would prioritize services based on patient safety, demand, and impact. Essential services such as care homes and long-term condition management would be protected first. Where capacity is limited, I would redesign how services are delivered rather than closing them. For example, by using more flexible staffing and blended service models.
Okay, thank you so much.
Any
Hi,
other?
Juliet. I
Hi.
have a question for you. In your presentation, you said you would recommend keep the services open. My question is, why did you recommend keeping the services open instead of closing it?
I recommended keeping services open because closing them creates more problems in the long term. Services closure reduce public trust, increase pressure on acute care and worsen health outcomes. Keeping services open and redesigning them supports workforce stability and provides more sustainable care.
Oh, thank you so much for your answers,
Yeah,
Juliet.
thank you. Thank you.
All right. Hello, everyone. My name is Marvelous, and
That's marvelous.
I'm yeah, and I'm here to discuss about the workforce sustainability and service capacity and how it affects my role as the human resource manager. And this is going to focus on the key challenges and the impacts of how these strategic solutions can really help the health and social care. So, to begin, the workforce sustainability refers to an organization the ability to attract and develop and also retain enough employees. Yes, and to meet both of these current and future demands, a sustainability workforce ensures continued care to reduce shortage and also support high quality service. To deliver this, we closely have to link it up with service capacity, which refers to the maximum level of service output of the organization. And we can also safety effectively and also provide available resources such as staff, funding, and the facilities. This is very crucial in the workforce. However, several challenges have threatened the workforce sustainability and service capacity. One major issue is the high staff turnover, particularly as we know in care homes. This is often caused by low pay, high workloads, and limited opportunities for career progression. Is really going so bad. And another challenge is the shortage of trained staff in voluntary sector. We organizations frequently rely on volunteers or employees with minimal training. It's really draining. And despite increasing this complex care needs, it's really not actually giving us what we want. In addition to this, rising the cost due to inflation, we have increased expenditure on wages and also utilities and supplies, while funding has not actually increased, it's still at the same rate. But we have come up with a plan. Finally, low service uptake and public trust issues. This often drive negative media coverage and has resulted in inefficiency and in the use of the resources. These challenges significantly affect the safety and effectiveness of care delivery. So the shortage of staff have increased the workload, the stress, and rising the risks of errors and missed care. Inadequate training leads to inconsistency. So we're going to close all of these gaps by providing quality service. Why the high turnover and unutilized services result in financial inefficiency. Furthermore, a damaged reputation discourages early engagement and service placing, further giving the system a lot of pressure. So we have management theories. I and my team are coming up with management theories that will help ease out these issues. So the Maslow hierarchy of needs, it highlights and show how unmet basic needs such as fair pay and job security contribute to high turnover. And also the Heber's two-factor theory suggests that why pay prevents dissatisfaction, motivation and performance improve through recognition and career development is additional. So additionally, the resource-based view emphasizes that employees are key organizational assets and failing to invest in them weakens the organization and the service capacity. In response to that, we are going to strategically recommend that these improved payment should be done, and also the working conditions should make the employees feel secure, and they should also, when they feel secure, they deliver their job in a very excellent way. And also we should invest in education and training. Yeah, in 3 months, 4 months, at every intervals we train the staff so that they can have that idea that they are actually being monitored and actually giving their best. So implementing all of this, we create an effective workforce planning, adopting supportive technology, and rebuilding our public trust through communication and engagement from the residents and everyone in these different care home facilities. In conclusion, the workforce sustainability is the foundation of service capacity. Without a stable, skill and motivated worker, the workforce is not safe, and so effective care cannot be delivered. But with strategic human resource interventions, we are able to have essential securing a very long-term service quality and organizational sustainability. Thank you. If you have any question, you can ask me, and I'll be so happy to answer that. Okay.
Okay, Mavi, thank you so much. A
Mm.
question for you is, why is workforce sustainability critical to service capacity in healthcare and social care?
Okay, the workforce sustainability is very critical to service capacity because the staff availability, the skills, and the sustainability directly determine how many service users an organization can support safely and effectively. So without sustainable workforce and also service capacity, if it's reduced, regardless of the available funding or facility, it's not going to achieve what it wants. But the high staff turnover and skill shortage leads to increased workload and staff fatigue, and also the service disruption, which negatively
Okay.
affect the quality of care and the safety. But a stable, well-trained workforce enables continuity, care effectiveness, efficient use of resources, and better outcome for the service users. So therefore, sustaining the workforce is essentially to maintaining the service and also capacity and long-term organization resilience. This is actually going to work in any organization. Thank you.
Okay. Thank you.
Okay.
Hi, Mari. Hope you're doing good. I have a
Yes.
question for you.
Okay.
As you said, if funding is limited, why should an organization prioritize workforce investment over any other area?
Okay. As an organization, we should prioritize workforce investment because employees are primarily drivers of the service we offer. The employees are the ones that actually transfer this service and they deliver it directly. And this service is determined by the capacity, the quality, and the safety that is being carried out while they do this. And without sufficient trained and motivated staff, the investment in these facilities, the equipment and the expansion cannot be effectively handled. So, with workforce shortage and high staff turnover, which have increased recruitment costs, agency spending, and the risk of the service failure, which is now more expensive in the long run than preventive investment in retention and training. Investing in the workforce provides sustainability. When we invest on the staff that are carrying out this service, it helps the organization. It reduces errors, enhances productivity, and supports continuity of care. From a strategic perspective, the staff represent a core organizational asset, and prioritizing workforce investment. This ensures sustainability services delivered efficiently, even in the constrained financial conditions. So, with this, is actually going to be a very excellent organization at the end of the day. Thank you so much for all your
Thank you so
questions.
much for your answer. It
Okay,
was a great idea. Thank you so much.
you're welcome.
Okay, thank you guys. Hello everyone. It's me Soni Limbu. As a clinical director within an Hertfordshire local area partnership, my focus is workforce sustainability because it is now the most significant determinant of service capacity, patient safety, and clinical outcome. Workforce shortage are no longer a workforce issue alone; they are a direct clinical risk. As for the challenges, I will be pointing out the workforce instability and clinical risks. Nationally, NHS England report over 112,000 vacancies, and this is reflected it locally in Hertfordshire. Instability across the community service and care home disrupt the continuity of the care and place us at risk of breaching the Care Quality Commission safe staffing expectation. At the same time, reduce the workforce capacity within the VCSE organization limits the delivery of the patient service, particularly smoking and diabetic management, both prioritized in the Hertfordshire health and well-being strategy. Clinically, this creates an avoidable emergency admission and escalates the long-term morbidity. Finally, burnout and the psychological fatigue it significantly affect the performance, sickness, absence, and retention. Evidence shows the unmanaged stress directly affects the service capacity and compromise the patient safety. As for the leadership approaches, my response is grounded in three leadership framework. Firstly, transformation clinical leadership, which aligns the workforce motivation and patient outcomes. As a clinical director, this means creating a shared clinical vision, empowering the multidisciplinary leaders, and placing the safety and quality ahead of short term. Secondly, system leadership. Workforce challenges do not respect the organization boundaries, fragmented the planning across the NHS provider, council, and VCSE, which means voluntary community and social enterprise. Partnership limits the capacity, system leadership enables and shares the accountability, coordinating and planning, and collected the problem solving across the entire pathway. Thirdly, I will be speaking about the demand capacity flow framework to redesign the service without resorting the closure or ensuring the capacity matches the clinical demand. Lastly, I will be speaking about the recommendation and the strategic solution. As for that we must strengthen the VSC organization clinical capacity throughout the strong government's competency-based training program and clearly escalate the pathway. Critically, workforce well-being is treated as a capacity protection with supervision time and psychological support and safe workload monitoring into a service delivery. In conclusion, protecting the workforce protects the patient and a retention first strategy integrate the workforce planning and investment in prevention are not optional. They are critically necessary to sustain a safe service capacity across the Hertfordshire. So this is the end for my presentation. If you guys have any question, and then you can raise your hand.
Thank you so much for your presentation, Sony. I have a question for you. You have said
Okay.
about the workforce shortages. So, why do you think it is necessary to invest in the prevention during this workforce shortage?
Okay, thank you for your question, Safa. When service are stretches, prevention can feel like something we cannot afford to prioritize, but actually it's an opposite. Investing in prevention reduce pressure on the system over time. For example, straining the smoking and diabetic service helps the patient avoid the hospital admission and delay the complication. That means fewer patient meeting the urgent or the complex care later on, which directly demand on acute service. There's also a big impact on health inequalities by targeting a high risk group and supporting the people to manage their own health. We can improve the outcome and reduce the future demand in the area that need it most. And most important, if we monitor the outcome properly, we can show that prevention isn't just a nice to have, it actively free up the capacity and improve the service sustainability. Thank you for your question.
Thank you.
Okay, Mark, Sonny, sorry. I have a question for you. Why focus on retention over recruitment?
Okay, firstly on retention, I'll be talking about the retention one. Recruitment alone isn't enough for an organization. If we can't keep the staff we already have, if people keep leaving, we constantly trying to fill the gap, which is costly and disruptive. Focusing on retention helps stabilize the service. Experienced staff already understand the system, the patient, and how team works together. That means better continuity of the care and less reliance on agency staff. From a clinical perspective, it's even more important that experienced team makes a fewer error, manage or risk better, and achieve a stronger patient outcome. They also play a key role in supporting and developing the junior colleague, which strengthen the whole workforce. So in a way, retention increase the capacity without needing to recruit more people. Thank you.
Thank
Yeah.
you.
Yeah, hello, hi everyone. As you all know, my name
Hello.
is Mumadi Fatima, and today my role is Patients Choice Lead. So basically, I'm the voice for the people of Hertfordshire. So coming to my role is patient choice role. As a patient choice lead, my major role is to ensure all the people across Hertfordshire have the access, can understand, and actively engage with the healthcare services available for them. Basically, patient's choice is directly linked to the service uptake and uh, outcomes. For an example, the issues what we organizations has been facing right now is workforce instability, as we all have been discussing over this. So the high staff turnover affects the care. Does it affect the confidence of the patients? Second one is increasing in cost. There are numerous financial barriers to the healthcare services which the people of Hertfordshire are facing right now. Coming to the third issue, that is the reduced trust in the people. Reduced services due to lack of trust because of unacceptable level of trained staff or in the voluntary or the community sectors. Major takeaway here is if there is low trust and low awareness in the people, this will lead to the reduced services and has a risk of closure. The other problems which I identified is the first one is a major waiting list. You know, in some areas, the hospitals or the services have less people, or in some areas, hospitals has many patients, increasing the waiting list. Next is no access, limited access, or the awareness. Services are available for the patients are available for the patients and elderly people, low income groups, due to digital exclusion because they don't know what are the services available, because they don't know how to use the digital services, etc. Second, the third one is service access inequality. For an example, urban rural disparities in the Hertfordshire. Now, coming to the leadership styles or the theories here, the very first, our favorite leadership style, I would say the transformation leadership, which is very different from transactional leadership. In transactional leadership, it is all about supervision process, organizations, and performance of the group that states people work better if they have sense of mission. But whereas transformational leadership theory necessitates that the leader should be able to inspire people, motivate people through communication in a way that they feel sense of unity. The leader must possess passion, vision, empowerment skills, and can be considered that hence he can be considered as a transformational leader. The second leadership theory I would select is a shared leadership style. In shared leadership style, there is distribution of decision making power throughout the team, enhancing teamwork, improving patient care, and making employees happy. Whereas in shared leadership style, not only if I'm choosing this style, I would also include the decisions of the patient as well as my whole team who are working together. This process depends on good teamwork, common values, and flexibility of the change, according to Oman Medjay and Abdul Aziz Al Sawal. Next, coming to the models or the frameworks which I'm going to use is shared decision making model. People get People get help in making decisions that they think are correct for themselves. The role of physician is in assisting the patient making a decisions of the treatment. The discussion will combine the expertise of the physicians, like their treatment options, facts, risks, and benefits, whereas the knowledge of patient regarding the preference, personal situations, goals, and beliefs are equally important. This is according to NHS England. Coming to the next, the five shared approaches has five major essential steps. First one, seek your patient's participation. Help your patient explore and compare treatment options. Assess your patient's value and preferences. Reach your decisions along with your patient. Next, evaluate your patient's decision. These are the five major steps in shared approach. Coming to the next framework, which I'm going to use, is patient-centered care model. Creating a workforce and community that exhibit attitude, ability, and skill conducive to and instrumental in delivering a patient-centered approach to well-being, prevention, care, and support. This include they have a few principles. For an example, care and support should be person led. Services should be designed in partnership with citizens. Careers should be supported. Major focus should be on narrowing inequalities and maintaining equalities, etc. Coming to the next framework is equality of access framework. People should be able to access support, care, treatment in timely manner when they need to and in a way that best work for them, promoting equality, removing barrier or delay, therefore protecting their rights. My recommendations overall for this HR challenges, for overall challenges is to develop an understanding of the patient as an individual, including how the condition affect the person, how the person's circumstances and experiences affects the condition and the treatment. Support shared decision making and patient involvement, which is a very important step according to NICE. Next, in order to retain staff, the training and education should be improvised, retained by supporting people's career, improve productivity by providing trainings and working in different ways. Community-based services, for an example, mobile clinics should be initiated because that will, decrease the cost and hence, patient can get easy access to the treatments. Next, we can also use community-based centers. Next, my recommendations will be digital awareness. There are many people who don't know how to use the digital platforms. So there should be some people working on this, how the people should know to use digital devices. Digital awareness should be an important thing to be worked on. The very last one is financial support systems. We have to work on our financial system in order to maintain our financial stabilities. That's all I have to present from my end. I'm open to answer any questions or inquiry if you hold any. Huh?
So for Fatima, I'll be asking you one question. So I have a doubt. So as a patient choice leader, what leadership you support more, transformation or a shared leadership?
Thank you for the question. I would say it's an interesting one, and I would love to answer that. There are many leadership styles present, but the one which I normally prefer is a shared decision making. The distribution of decision making power throughout the team and including the patient in the decision making is an important step. As the role indicates that the patient lead the role which I'm holding. So taking others' opinion, ideas are also important. You never know who can give you an important idea. So basically, my thoughts are I will include everyone, whomever I'm working with, my team, my juniors, my seniors. Even if I'm confident in a decision, still I would take someone's opinion because their opinion matter, and I can improve my perception as well. So I normally prefer. I know many people prefer transformational leadership style, but normally I prefer shared decision making leadership style. Yeah.
Yeah.
Thank you for your answer. Thank you so much.
No worries, no
Okay,
worries.
Fatima, I also have a question.
Oh,
I
Marvy
also
is holding
support,
a question for me. Wow.
yeah, I also
Okay.
support the transformational leadership and sometimes shared leadership. Well, it depends on the capacity. Okay,
Mm-hmm.
my question is why do you think there is reduced service, and how can we prevent them from happening? And
Okay. Thank you for the question, Marvy. The major reason why there is reduced trust in services because uh, people don't know what are the services available, what an organization is offering. For an example, what conditions can be treated, what people can visit them, everything. So basically, if they know what services are present in your organization or in my organization, people will have more trust on you. People will keep on visiting you. If they don't know how you're treating, how you're, uh, reaching out to them, etc. And other major reason is because of untrained staff. I see many organizations has few people where people are not trained up to a mark, or they are not, even though if they are trained, they are not exhibiting their expertise.
yeah,
So in order to prevent this, I would say the staff should be well trained, and there should be some digital awareness to tell people. Just like not only digital awareness, you can also go with some campaigns, reaching out to people's and say how your services are being delivered, what are the services available in your organization. My major focus will be digital access to tell people how can they use some digital and come into the picture and contribute towards it, have the access, understand, etc. Yeah.
all right. Thank you for
Thank
answering the
you.
question.
Yeah.
Thank you, everyone.
All
Thank you,
right,
Thank you,
everyone.
everyone.
thank you. Bye.